The listening part of the occupational English test has 3 parts, and in each part you will hear a number of different extracts. At the beginning of the test, you will hear a beep sound. You will have time to read the questions before you hear the extracts. You will hear each extract once only. You have to complete your answers as you listen. At the end of each test, you will be given 2 minutes to check your answers. Part A. In this part of the test, you will hear 2 different extracts. In each extract, a healthcare professional is talking to his patient. For questions 1 to 24, complete the notes with the information you hear. Now, look at the notes for extract 1. Extract 1. Questions 1 to 12. You hear a physician talking to a new patient, called Mrs. Delilah. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, doctor.
Good morning. What's your problem?
Well, I have persistent mild weakness in the left leg and occasional off and on numbness in the left hand. I have shortness of breath often.
Do you feel any weakness in your arm?
No, doctor, but I am ambulating with a cane.
Was there any history of falling down?
No, doctor. I had repeat carotid Dopplers and further imaging studies shows no further increased stenosis in my left internal carotid artery.
Okay. What is your age?
51, doctor.
You had any illness and treatments?
Yes, I had cerebrovascular accident but got treated.
What medications are you taking?
Plavix, aspirin, levothyroxine, lisinopril, hydrochlorothiazide, Lasix, insulin, and simvastatin.
Any allergies due to medications?
No, doctor.
Is there any history of illness of your family members?
No, doctor.
Well, your blood pressure is 170 over 66, heart rate 66, respiratory rate 16, your weight is 254 pounds, and your temperature is 98. Normal cephalic and atraumatic, no dry mouth, no palpable cervical lymph nodes. Your conjunctiva and sclera were clear. Your cranial nerves show mild decrease in the left nasolabial fold. There is a mild increased tone in the left upper extremity. Deltoid shows 5 over 5. The rest shows full strength. Hip flexion is 5/5 on the left. The rest shows full strength. Reflexes were hypoactive and symmetrical. Your gait is mildly abnormal. No ataxia noted. Wide-based, ambulated with a cane. Status, post-cerebrovascular accident involving the right upper pons extending into the right cerebral pedicle, with a mild left hemiparenthesis. Status, post-cerebrovascular accident involving the right upper pons extending into the right cerebral peduncle, with a mild left hemiparesis, has been clinically stable with mild improvement. For now, continue using antiplatelet therapy and statin therapy to reduce the risk of future strokes. Continue to follow with endocrinology for diabetes and thyroid problems. You must strictly control your blood sugar level, optimizing cholesterol and blood pressure control, regular exercise, and healthy diet. I am planning for surgical intervention for the internal carotid artery.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello there, my name's John, and I'm going to be the doctor that's looking after you today.
Hello, John. Nice to meet you. And thanks for seeing me today.
How should I address you?
Just please call me Kevin. Yeah, I'm here today because I had a bicycle accident on Sunday morning, and I was wondering if you could check me out. I've hurt my shoulder and my wrist, and I'm just a bit concerned about it.
Okay, Kevin, this is the first time that we've met, I believe.
Yes.
Can you tell me a little bit about yourself?
Well, I'm 53 years old. I'm in pretty good health. I'm about 83, 85 kilograms. Probably could lose a bit of weight. My cholesterol's at lower than average levels by far.
And what about your blood pressure? Is somebody checking that regularly?
Yes, again, fine. If not on the low side, yeah. If anything, I tend to be on the low side of blood pressure and that type of thing.
And you're not on any medications at the moment?
No, nothing.
Are you allergic to anything?
No. Never been allergic to anything. I bicycle regularly about 100 to 150 kilometers a week.
Have you ever smoked?
No.
What about alcohol?
Not too much. I tend not to drink that much at all.
When you do drink, what do you prefer to drink?
Recently, I've been just having New Zealand whites, actually.
Yes. And how many glasses a night would you have?
In a week, 3 to 4. I mean, but that's like 2 on a Friday night and Sunday afternoon. That kind of drinking. It's pretty light, really.
Okay.
I'm conscious of drinking and smoking.
Any history in your family in terms of your mother and father with diabetes or heart attacks?
No, nothing like that. No, yeah, my mother was a heavy smoker. She was a very strong woman, but she smoked a lot. My father also had a bit of heart problems. He ended up having a pacemaker for 30 years of his life. I'm 53 years old. He got a pacemaker at 54, so I'm very conscious of again, staying in shape because of my father's experience. He had that for 30 years.
But it was never that he had a heart attack or...
No, it was just simply the heart started. He lived till 84, 85 years old, so perhaps I should tell you one part of my life story. I was in West Africa for several years. Probably the biggest health crisis in my life is living in West Africa for a long time. Have a lot of stomach problems, problems with giardia, malaria, and actually amoebic dysentery. Those infections brought my weight down to about 60 kilograms, so just terrible, if you will, diarrhea constantly.
Yeah, and I imagine that you would have required medical treatment for your various conditions as well. Did you spend any time in hospital?
So we used to go to the local embassy and get treated by embassy medical staff. At the time, we were getting 500 milligrams of the anti-malaria medicine chloroquine, and then we had various antivirals and shots, but pretty minimal medical care, to be honest. Yeah, but since then, I've been fine, actually. I've been here in Australia about 20 years and was originally born and raised in the States.
I see. Can you tell me more about the accident?
Yes. Just recently I went over the top of a friend I was bicycling with, went over the top of him and ended up just smashing myself on the asphalt. And I hurt my shoulder. Yeah, it's terrible. To be honest, he wasn't paying attention. We had just stopped and they were just getting going again. It was Sunday morning. He slammed on his brakes and then I went over the top of him and then into the traffic, and luckily, I pushed both of us out of the way before a car came roaring past. And
wow, that sounds like quite a large accident. Everybody managed to walk away from it okay?
Yeah, we were laughing about it,
You didn't need to call the ambulance or go to hospital for anything at the time?
No, we didn't even think about it. It was, again, we were laughing about it and went to the coffee shop. It was only, as I came home and after the coming home and resting for a while, I realized I was in more pain than normal, if you will.
How long before the pain started to come on?
Right after having coffee, to be honest. I think the adrenaline went down, and just coming home and finally kind of reflecting on the whole thing. After the accident, as you know, bicycles have...
Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a pharmacist talking to a patient. Now read the question.
Hi, I'm dropping off a new prescription.
No problem, I have this in stock, but I do notice that this prescription is from the hospital. Can you tell me more about that?
Yeah, I was in the hospital for about 10 days. I need my refills as they didn't give me any new prescriptions in the hospital.
I did have auto refills for you in the pharmacy. Unfortunately, I had to return it to stock since you weren't able to pick them up. But, if you give me 20 minutes, I can get them all ready for you.
I twisted my ankle leaving the apartment this morning. It's hurting real bad.
That's terrible, especially since it's your first day coming back from the hospital. But I did want to talk to you about one thing. The ibuprofen that you're holding, especially with your medical condition, will have a tendency to reduce blood flow to your kidneys.
Really? They told me I couldn't take Tylenol, but I thought that ibuprofen would be okay. At the hospital, they said my kidneys weren't doing too good when I first got there. But when I left, they said everything was back to normal.
Question 26. You hear a discussion between a nurse and a physician explaining about Nipah virus. Now read the question.
Hello, doctor. Can you explain what the Nipah virus is?
Well, Nipah virus is a member of the paramic severity genus Henipavirus. This Nipah virus was initially identified and isolated in 1999 during an outbreak of encephalitis and respiratory problems among pig farmers and other people with close contact with pigs in Singapore and Malaysia. The name of the virus originated from Sungai Nipah, a village in Malaysia where pig farmers became sick with encephalitis. Initially, the disease was linked with Hendra virus, emerged from bats, but was quickly singled out for investigation, and flying foxes of the genus were subsequently identified as the reservoir for the Nipah virus.
Question 27. You hear a radiographer talking to a patient about her MRI scan. Now read the question.
Come in. Mrs. Brown, isn't it? My name's Ted, and I'm going to be doing your MRI scan today. Now, can you get up on the table for me?
You know, I'm really claustrophobic.
Well, this is a new piece of equipment. The diameter is much larger, so it should make it a little more comfortable for you. You'll also have this call bell, so if you need me at any point during the test, you squeeze that, okay?
Okay.
Now, your scan's only going to take about 15 minutes. Are you okay with that?
I am.
Okay, let's get started then.
Question 28. You hear a nurse reporting to the doctor regarding a patient. Now read the question.
Hi, Dr. Walker. Yes, this is Carolyn Hall. I'm calling concerning Virginia Woolf in 347B. She's a para 1, gravida 1, and she has a massive amount of bleeding that saturated her bed and is pooling on the floor. Yes, and right now she's unresponsive and her blood pressure is 86/40. Her heart rate is 122, her respirations is 12, and her O2 sat is 90% on room air. Yes, she had an uncomplicated vaginal delivery this morning, and we gave her some Percocet and Ambien about 90 minutes ago. She has a saline lock on in her right arm, and it looks like a hemorrhage, and I think you should come and assess the patient.
Question 29. You hear a pharmacist talking to a doctor about a patient's medication. Now read the question.
Sorry to bother you, Dr. Anderson. I just wanted a quick word about Mrs. Campbell's prescription. The one for diphenhydramine that you gave her last week.
Oh, yes, for her allergies.
Yeah, so she's been taking 50 milligram tablets for about a week now. The thing is, she's just been into the pharmacy and she says that the tablets are making her feel really drowsy and her mouth's really dry, ever since she started on the pills.
Really? Well, that does happen from time to time. But maybe switching her onto a different medication wouldn't be a bad idea.
Okay, I'll look into some options and then run them past you later, shall I?
Fine, thanks.
Question 30. You hear two doctors doing an activity at a staff training day. Now read the question.
So, what did the trainer say we have to do?
Well, we've got to look through these case notes, 10 sets in total, and decide which of the patients should be referred to the consultant as a matter of urgency and which can wait.
Oh, right. And did I hear him say there's a limited number you can refer?
Not exactly. He said that we should put them in rank order according to the severity of the symptoms and other factors evident from the case notes. Once we've agreed on our list, we have to go and compare with another pair of trainees.
Okay. Let's get started then.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the monologue of a physician giving a lecture on the different types of non-Hodgkin's lymphoma. You now have 90 seconds to read questions 31 to 36.
The two main categories of lymphoma are Hodgkin lymphoma and non-Hodgkin lymphoma. Non-Hodgkin lymphoma is a large group of diseases with different symptoms, treatments, and outcomes. The appropriate name of the type of non-Hodgkin lymphoma may include a number of descriptive terms that can be difficult to understand. Lymphomas arise from lymphocytes, a type of white blood cell, which are of two types, T cells and B cells. Both help in killing infectious agents, however, in slightly different ways. Based on the type of lymphocyte turned into the cancer cell, the patients may have a T cell or a B cell lymphoma. B cell non-Hodgkin lymphoma is the more common type. There are many different types of B cell and T cell lymphomas, each behaving in a different way. Pathologists performing biopsy of the tumor define the cancers in terms of grade. High-grade lymphoma cells look quite different from normal cells. They tend to grow aggressively. Low-grade lymphomas have cells that look much more similar to normal cells and multiply gradually. Intermediate-grade lymphomas fall somewhere in the middle. The behavior of these types is also described as indolent and aggressive. What the pathologist describes as a high-grade or intermediate-grade lymphoma usually grows fast in the body, so these two types are considered aggressive non-Hodgkin lymphoma. Surprisingly, aggressive non-Hodgkin lymphoma often responds better to treatment, and many people with aggressive non-Hodgkin lymphoma are cured if they are diagnosed early. The most common kind of aggressive lymphoma is diffuse large B-cell lymphoma. On the other hand, low-grade non-Hodgkin lymphoma grows gradually, and these lymphomas are therefore called indolent non-Hodgkin lymphoma. This group of non-Hodgkin lymphoma doesn't give rise to too many symptoms, but they are also long-standing and are less likely to be cured. The most common kind of indolent lymphoma is follicular lymphoma. At times, indolent lymphomas can transform into more aggressive. The majority of lymphomas are nodal lymphomas. That means they originate in the lymph nodes. However, it is possible for lymphomas to arise from anywhere else. When the lymphoma is mainly present in nodes, it is called nodal disease. Occasionally, most of the lymphoma may be in an organ that is not a part of the lymph system, such as the skin, the stomach, or the brain. In such condition, the lymphoma is referred to as extranodal. Therefore, nodal and extranodal refer to the primary site of the disease. A lymphoma can develop in a lymph node and then involve other parts at a later stage. However, in such a case, it is still considered a nodal lymphoma, but is said to have extranodal involvement. In follicular lymphoma, the cancer cells arrange themselves in spherical clusters called follicles. In diffuse non-Hodgkin lymphoma, the cells are spread around without any clustering. Most of the time, low-grade non-Hodgkin lymphoma looks follicular, and intermediate or high-grade non-Hodgkin lymphoma looks diffuse in biopsy. Non-Hodgkin lymphomas are also described as common or rarer based on the statistics of the new cases every year.
Extract 2. Questions 37 to 42. You hear an ophthalmologist called Dr. Ralph Peterson giving a presentation. You now have 90 seconds to read questions 37 to 42.
Hello, everyone. My name is Dr. Ralph Peterson. I'm an ophthalmologist and a specialist in photochemistry. I will be talking about the genetic model and how does it fit in optometry. Well, genetics is being incorporated into medical care in terms of dealing with disease and specifically in one of the really critical areas of pre-symptomatic evaluation, or in other words, it's being able to intervene before the symptoms. The advantage of that, of course, is that you delay the onset of the disease and then, when it once manifests, you can delay the progression hopefully, and also decrease the severity, and things like that. So, this is already being done, and interestingly ocular disease represents really a better sort of venue, so to speak, than systemic disease, because there are a whole bunch of ocular diseases that result from a single mutation in one codon. Lots of these systemic diseases like heart disease, hypertension, diabetes and other things, the genetic contribution is very complex. There are multiple genes and multiple sites, and there are all sorts of complications and complexities in terms of applying that to actual clinical care. Even though it will be done, but it will take a longer period of time. There are all these studies going on like the 1000 Genomes Project. The genomics is already being applied in terms of ocular disease. I read a paper where they were looking at mutations in rhodopsin. If the mutation occurs in that area, it tremendously affects how rhodopsin responds to light. It does so because the rhodopsin to respond abnormally, and it does result in disease. But it's not quite as drastic as in the first sign. We were able to show this with standard measurements that one would do in a clinical setting such as visual acuity, visual field diameter, dark at that sensitivity, ERG amplitude. But, it's not something that optometry is identified with. There are two categories. The first category is genetic testing, useful in terms of the things that I mentioned. I think the second issue is in terms of optometrists dealing with ocular disease. The public recognizes optometrists as being viable health care providers in terms of ocular disease, and I feel now this entire thing could be in jeopardy if optometrists don't get involved with genetics. When someone presented with some sort of ocular disease, we are already at the 5-year point. It's not a question of if this happens, it's a question of when it's going to happen. Okay, I have no idea when it's going, but it's going to happen, and optometrists are completely unprepared for this. So what does that mean? Let's say some point, that's what the ophthalmologists start to do. In other words, you go in for an exam for an ocular disease and they will draw blood and send it out for genetic analysis, and optometrists aren't doing this. So in terms of the public perception, what does that mean? So in my mind, it's sort of analogous to, let's say you going to your internist for your yearly checkup and the person not drawing blood to do, let's say, a lipid profile, so who's going to continue to go to such a person? Most of the ophthalmologists are doing genetic testing and helping patients with that. In fact, I think just about everybody involved in ocular disease in the ophthalmology community is doing this as part of standard care routine. As I said, there are a few optometrists here and there who are doing it. But, it's not something that is recognized universally in optometry, and, more importantly, as I said, we're not training students to get involved in this area. In terms of the mundane aspects, including insurance, I think there are three things in general that are happening, that are pushing genetic testing more and more into clinical care, ocular as well as otherwise. One is that the amount of money it costs to do the analysis is coming way down. The second thing is the length of time it takes to do an analysis is speeding up very significantly, and perhaps most importantly, the insurance companies are starting to cover the tab because they are beginning to realize that it will cost them less in the long run. So these are all important issues that are driving genetic testing into a standard medical care. Now, both nutrition and genetics are becoming part of issues that are important in terms of ocular disease and specifically in age-related macular degeneration. So, one of the things that has happened just over the last couple of years is some models have been set up which look at a bunch of different factors, including genetics, environmental, diet, nutrition, demographic and ocular factors that can predict how likely it is that someone is going to develop AMD, and once it develops, what the likely progression characteristics are going to be. But again, showing you how both these areas are becoming vital in terms of dealing with ocular disease concludes it. That is the end of Part C. You now have 2 minutes to check your answers.